Welcome back to Your Smarter Heart University. Folks, we're sorry for the technical difficulties with the radio station. As always, we will, if we got cut off from last week, we post you a full show on smarterheartuniversity.com, which is edited and usually won't have any of this. But we apologize for that from our standpoint. So we didn't get a chance to go out to the break with our pop quiz. And my apologies to Dr. Kaiser for getting cut off there. But the bottom line is we'll get it all straightened out for you folks. Here was your pop quiz, Bob. Who has a worse 5-year survival? A person with breast cancer, a person with symptomatic PAD, or a person with Hodgkin's lymphoma?
Well, I'm going to say the PAD.
Because you're
I'm the PAD guy.
Because you're the PAD expert. Well, of course, he's going to be right. But that was our pop quiz going out to break for all of you. The 5-year mortality rate for symptomatic or advanced peripheral arterial disease is 28%. Almost 30% of people will die if not treated effectively. Greater than breast cancer at 11%, or Hodgkin's lymphoma at 14%. So major statistically worse to have PAD.
Right, and that just gets right to the fact that cardiovascular disease, and that we're talking about the vascular part of cardiovascular disease today, is the #1 killer of people.
Exactly. So since PAD is more common than you think, and increases your risk of heart disease or stroke 5 to 6 times in 10 years once you have produced symptoms, once you have walked in and said, hey, my legs hurt, hey, they're weak, it's essential to make the diagnosis as early as possible. Remember I said the eyes are the windows into the soul out to the break. Hopefully that got in there. But it's your legs are the windows into your heart. You have 10 years, folks, to be able to do something about it. So in general, your history or your physical exam are just not reliable to detect PAD. 90% of the time, I said it the first segment, I'm going to say it a number of times, the diagnosis of PAD can be missed. So in 1996, 1,600 men and women were studied for about 5 years using a simple and inexpensive method to confirm the clinical suspicion of having PAD. It measured the pressures in your legs divided by the pressures in your arms, known as an ankle brachial index, or an ABI, for the rest of this show. It has since extensively predicted subsequent cardiac events. Remember, I didn't say leg events, I said cardiac events in people with a low ratio. Well, what is a ratio? A normal ABI is considered to be between 1.0 and 1.3. And Bob's probably going to have something to say about that because, again, he is the expert. Anything less than 0.9, and I know he's going to agree with me with that, that ratio, 0.9, is considered very sensitive and specific, meaning that you have it to detect a blockage of more than 50%. And once the number is less than 0.5, there's a very significant high risk of heart disease, stroke, and dying from any cause. Now, once you get below 0.4 or anything less, it signifies what we call critical limb ischemia. And what that means is there's a severe loss of blood supply and oxygen due to a severe blockage to that affected leg with a very high risk of amputation or limb loss unless it's corrected immediately. Now, an interesting finding is when the ABI is higher than 1.4, this can actually be considered also high in terms of cardiac risk or a false positive. And this is, especially if you have leg pain and have a high number, and this is due to more stiff, calcified vessels, the quote-unquote hardening of the arteries. They can happen in your legs, folks, just like in your heart and your brain. And they're not compressible. They're so stiff that you can't take a blood pressure in your legs. So if your ABI is high, that can be a problem. Also, your ABI can be normal at rest, but much lower with your activity, so that if the index of suspicion is high, if we think you have it, if a doctor thinks you have it, measurements are often taken at rest before and then after walking up and down the hallway. Oftentimes, I'll see, I'll start a patient, I'll see a patient in the office, and, go see the next patient, and I've got that patient that I just saw, walking up and down the hallway, making laps and bumping into everybody. But it's a very important thing because your number can significantly drop with activity, and that's a good indicator of peripheral arterial disease. So who should get an ABI? The most important risk factors include if you're older than 70, if you're between 50 and 69 and either smoke or have diabetes, if you have typical claudication symptoms, which we previously just described, if you have an abnormal exam on your legs, like the hair or ulcers or non-healing wounds, or if you have significant pain at rest. These are the current guidelines that recommend routine use of the ABI to screen for PAD. But unfortunately, there's also guidelines that say we shouldn't be doing it routinely, and reimbursement has always been a problem for doctors. But what if you have a low ABI? If the suspicion is high for PAD, your cardiologist or your vascular surgeon is going to perform an angiogram of your lower extremities. It's done similar to the catheterizations that Dr. Kaiser and I do, where we put a sheath in your left or right femoral artery that's in your groin area, and depending on the location and the severity of the blockages, either an endovascular procedure where various devices such as balloon angioplasty or stents or other mechanical plaque busters and removers, which we're going to let Dr. K talk about in a second, can be performed through the same sheet that we put in to do the diagnostic angiogram. Likewise, if called for, again, based on location and anatomy, bypass around these blockages can be performed by a vascular surgeon using synthetic grafts to restore the blood flow back to your leg. Now, if the suspicion is borderline, a non-invasive angiogram, like a CAT scan or an MRI approach, can be used to image your lower extremity arteries. I'm going to cut because this is your area.
Well, yeah, the issue about the ankle brachial index is important. There are two components to that you were talking about. The first is that the ankle brachial index is important to diagnose or screen for the presence of peripheral arterial disease. And if you have it, that is a risk factor for a heart attack. And the worse a PAD you have, the higher the risk is, and you need to be addressing that risk. The other thing that we're talking about is the leg symptoms. So if you think you have PAD, if your legs hurt when you walk, if you have cramps at night, especially at night, if you have any kind of symptoms, talk to your doctor about it, because that may be a risk factor for heart disease that you need to be addressing. Let's talk about the legs here. Right. If you're having symptoms in your legs, then we need to deal with the legs, because now we're talking about a lifestyle factor. It's uncommon to get all the way to the point where you have bad circulation to the point where you're going to lose your foot. That's really bad, and we deal with that as well. But we should be able to get to you before you have the symptoms so bad that you're going to lose your leg. And so we're diagnosing or screening for with the ABI. Now, if I think that's a high risk, I'll take them straight to the cath lab and talk and do the angiogram. But the non-invasive stuff, also with the CAT scan or the MRI, paints a nice picture for me, if you will. We'll diagnose it further, localize where the blockage is, and see if there's something that I can do. And nowadays, with the balloons and stents, the endovascular stuff, we can go through a tube about the size of the inside of a pen in a hole in the groin and completely reconstruct the vasculature of the legs. I can go. The techniques now are available to go to fix stuff from the belly button all the way down to the ankle. So if you have problems, you need to bring it up to your physician, and if physicians out there are listening, you need to be asking your patients about this, because it's an important. Truthfully, the patients I've worked on in the legs are usually more appreciative than and have better quality of life than when I fix the heart arteries. I mean, it's remarkable how much lifestyle improvement we can get patients, and the techniques are fantastic. I mean, through basically no incision, we have a thing that's essentially it's called a Diamondback. It's essentially a roto-rooter. We have a laser. We have a catheter that shaves the inside of the vessel. We have all kinds of techniques available to reconstruct the vasculature in the legs, and and sometimes, like in the cardiac world, we have to bring our vascular surgery colleagues online and say, you know, this is not something that I can fix with balloons and stents. Maybe bypass is the right answer. And the nice thing is there are really good options for people with peripheral arterial disease to fix it and get them feeling better. But always remember, it comes back to you're not going to die from the blockage in your leg. You're going to die from the heart attack or the stroke that goes with it. So it's incumbent upon you as a patient, your physician, to not only deal with the legs, but also deal with the heart.
Right. Very well put. Let's go a pop quiz going out to the break. Persons older than 60 who are considered only low or moderate risk for heart disease, Bob, have a 10, 20, or 30% abnormal ABI.
I'll say 30.
Okay, 30%. We'll be right back on Your Smarter Heart University on AM 970, The Apple. I think we're back.